Outpatient podiatry requires you to move fast. You have high patient volumes, back-to-back clinical blocks, and a waiting room that never really empties. Yet underneath that intense clinical activity, the average podiatry practice is losing roughly $150,000 every year. That money does not vanish in a single massive write-off. It disappears in a slow, quiet bleed through consistently underpaid claims and unworked appeals that pile up at the end of each month. Most practice owners would prefer to focus their energy entirely on patient care. Instead, they find themselves pulled into the exhaustive routine of chasing down payers. Navigating prior authorization requests, specific modifier rules, and complex claim denials has made the administrative side of running a foot and ankle practice an incredibly time-consuming and error-prone job. When the underlying mechanics of your revenue cycle are compromised, you create a financial leak. You simply cannot outpace that kind of continuous loss just by seeing more patients. To see exactly where this money is going, we can look at federal data. The Centers for Medicare and Medicaid Services reported an 11.2% improper payment rate for podiatry providers in 2024. This cascading bar chart shows the breakdown of the $216.9 million in improper payments identified by CMS. As you can see, 76.4% of those errors stem directly from inadequate documentation, with incorrect coding driving another 11.5%. Almost 9 out of every $10 lost in podiatry billing traces right back to preventable administrative gaps. It is a workflow issue, not fraud, and those workflows are now operating under much tighter constraints. The CMS prior authorization reform rule, finalized in September 2025, compounded the pressure on your front office. This mandate explicitly cut the payer decision window in half, dropping it from 14 days down to just 7 calendar days. Because of this, routine podiatric surgeries and custom orthotics have become authorization landmines. A single missed detail on an L3000 claim instantly stalls cash flow. Traditional, manual administrative routines are mathematically incapable of matching the speed required by these compressed federal and commercial timelines. The primary friction point in this entire system is the personnel executing the billing. According to MGMA data, business operations and billing staff turn over at a rate of 33.3%. Your practice is likely replacing 1 in 3 billing employees every single year. Every time a frontline biller leaves, replacing them costs your practice between $25,000 and $30,000, and that is just the hard financial cost. The moment a primary biller resigns, your operations face an immediate domino effect. It takes a minimum of 60 to 90 days for a new hire to get up to speed and reach baseline productivity. During that 3-month ramp-up window, your claim volume slows down, denials go completely unworked, and your accounts receivable days steadily climb into a massive backlog. This is exceptionally risky in podiatry, where nuance dictates revenue. If an untrained staff member confuses the Q7, Q8, or Q9 modifier rules, it can reduce your reimbursement for a procedure by up to 50% or trigger a complete denial. Treating a highly specialized podiatry billing role as an entry-level, revolving door position practically guarantees your practice will remain stuck in a perpetual state of revenue backlog. Let's step back and look at the actual overhead. An in-house billing full-time equivalent costs between $55,000 and $75,000 a year. That base figure is incomplete. It entirely excludes the required benefits load, the training overhead, and the constant liability of turnover replacement costs. To correct your revenue cycle, that employee must execute strict evidence-based practices, front-end eligibility verification, real-time claim scrubbing before submission, and precise denial pattern tracking. You are left in a tough dilemma. You are paying premium salaries for in-house staff, yet failing to build the specialized, automated systems actually required to collect your revenue. A growing number of smart podiatry practices are solving this issue by shifting to dedicated, credentialed outsourcing. Specifically, the model developed by Staffingly provides a direct response to escalating in-house operating costs. This matrix shows the math. An in-house employee costs up to $75,000 with a 33% turnover liability. A Staffingly specialist costs $399 weekly with 0 turnover risk. This eliminates training and benefits overhead, running roughly $20,748 annually per seat. Operationally, Staffingly assigns AAPC and AHIMA-credentialed specialists who act as your dedicated team. They work directly inside your existing EMR every single day. These human specialists are supported by AI-augmented smart claim routing. The technology prioritizes their workflow, preventing queue bottlenecks during your high-volume clinical days. By combining specialized human credentialing with smart routing technology, client error rates consistently remain below 1 protocols, with a business associate agreement signed well before the kickoff. The commercial structure is built to limit your exposure. You operate on month-to-month terms with no long-term contracts and an easy 30-day cancellation notice. You have to balance the illusion of physical proximity, having an employee sitting at a desk nearby, against the mathematical efficiency of credentialed expertise. If you are tired of the billing staffing spiral, the lowest risk test you can run is to visit staffingly.com/demo or call 800-489-5877 to start a 30-day free trial.